Now let us move on to the next topic. The next topic which we have is hypospadias. So let's talk about how common is it. So this is the most common congenital anomaly of the urethra, period. Very, very important, okay? Now let us move on to the next topic. The next topic which we have is hypospadias. So let's talk about how common is it. So this is the most common congenital anomaly of the urethra, period. Very, very important, okay? So this is the most common congenital anomaly which we have of the urethra. It is common in, let's say, 1 in 250 live births, okay? Every 1 in 250 live births have some or the other form of hypospadias. Now, why? Why does hypospadias occurs? So during the embryological period, what do you have? There is basically urethral fold which basically fuses from the posterior to the anterior, okay? So during the embryological period, there is a urethral fold. There is basically a fold which is basically fusing from the posterior to the anterior part. Now what you need to understand over here, if at all there is, then your meatus is going to be present at an ectopic location. So the meatus is, let's say, opening on the ventral aspect of the urethra. That is what is called as a hypospadia. So I hope you got the drill. What is happening over here? During the embryological period, there is a urethral fold which is fusing from posterior to anterior aspect. And let's say if at all there is this particular fusion doesn't go through in totality, what is going to happen? The urethral opening is going to open on the ventral aspect. So this is what is referred to as a posterior urethral valve. Okay, I hope you are able to understand this point. Then on the basis of this, we can have either the anterior hypospadias or a posterior hypospadias. So what is included in your anterior hypospadias? So we can have a glandular and we can have a coronal. What is glandular? Glandular means that is obviously the urethral opening is basically present on the glans of the penis. Coronal means it is basically present at the junction of your glans, penis and the prepuce. And then you can have a penile, you can have a pinoscrotal at the junction of your penis and the scrotum. You can have scrotal and you can have perineal. So yeah, these are the different types of hypospadias which you can have. Now, if I just logically ask you, out of all these, which is going to be the most common type? What is going to be the most common type? So the anterior is going to be the most common type, okay? Anterior hypospadias is the most common. But if I ask you, which is something which is going to be very, very severe types? So obviously the posterior hypospadias, let's say the perineal or the scrotal or the pinoscrotal, this is what is going to be the most severe one. I hope you are able to understand this point, okay? So anterior, that is glandular and the coronal, that is going to be the most common, and the perineal or the scrotal or the pinoscrotal, that is going to be the most severe one. Okay, I hope you got this point. Pretty simple. I hope you understood. Now, let's move ahead and let's talk about the clinical features. If at all the patient is having hypospadias, what is the big deal? What problem is the patient going to have? The patient is going to have a problem in the urination. The urine stream will not be normal. The proper urination will not be able to happen. That will be the basic complaint. At the same time, there will not be a proper implantation of the semen. So yeah, this might lead to a subfertility in this particular patient. The semen will not be implanted at a proper place, and the act of fertilization may get hampered because of this. Okay, right. And yeah, the patient might complain of a flattened or the short penis. So these are the basic concerns which a patient with a hypospadias might have. Okay, now let's say if at all there is a patient in whom you are evaluating, there are 3 characteristic features. Okay, so when you're looking at the patient of a hypospadias, there are 3 characteristic features. This is what is giving your diagnosis. What is it? First, you have a dorsal hooded prepuce. Now, what do you understand by this dorsal hooded prepuce? I hope you're able to understand this particular part. This is what is an extra prepuce which you have. Why does it occur on the dorsal aspect? Because simply the ventral urethral fold did not fuse. And because it did not fuse, the skin did not fuse. And if all the skin did not fuse, you get a dorsal hooded prepuce. I hope you got this point. So there is an extra kind of prepusal skin on the dorsal aspect. Then you have a ventral cord. So there is a cord-like thing on the ventral aspects. Okay. So because the opening is present below on the ventral aspect, there is going to be a fibrous cord in the rest of the part of the penis, and that is what is going to cause a ventral chordae. Okay, so there's going to be a dorsal hooded prepuce, there's going to be a ventral chordae, and there's going to be an ectopic meatus. So the urethral opening is not going to be at a normal position, it is going to be present at an ectopic location. Obviously, these are the 3 characteristic features which you are going to have in the patients of a hypospadias. Now, when we talk about what will you do in this, will you perform a circumcision or not? So everybody knows we will not perform a circumcision. Circumcision is kind of contraindicated over here. Why so? Because we will use this particular skin to reconstruct the urethra. So in this particular patient, the distal part of the urethra is not developed, right? So the distal part of the urethra is not developed, and that part of the urethra, we can use this preputial skin to develop. So this is, let's say, the urethral opening over here. There's a fibrous cord over here. So once you are operating on this particular patient, you want to put a tubular structure over here. You can use this preputial skin in order to make this particular tubular structure, and that is why circumcision is kind of contraindicated. That's great. Now, if at all, let's say I ask you, when will you operate? So there is a patient with a hypospadias, the child is coming to you, mother is asking like, when would you prefer to operate? So what you need to understand is you basically operate between 12 to like 6 to 12 months. You basically operate before 18 months. You should not prolong the surgery beyond 18 months. There's a reason for that. It should be operated before 18 months. The reason is because after this point, the child will have the gender identity, and any kind of a surgery which you basically perform in the genitalia of this particular person or the child, it will be considered as a genital mutilating surgery, and it may kind of hamper with the psychology of the child. And that is the reason why we have to operate in the patients of the hypospadias ideally before 18 months. I hope you got this point. Okay. Now, there are n number of surgeries. Nobody's going to ask you those particular things, so a super, the kit and whatnot, magpie procedure and all this stuff. Just remember that nowadays we have something which is called as a tip. Now, what is this tip? This is tubularized incised plate. So what we have noticed is in these particular patients in the hypospadias, even though the urethra is not developed, we still have a urethral plate which is there. So what we basically do is we incise that particular urethral plate and we use it to kind of make the tube. So that is what is called as a tubularized incised plate. Don't go into details of it. It is basically the modification of the snot grass and everything. Don't go into the details. Okay. So obviously, if you are a urology student preparing for the urology, you must have read about all these particular surgeries in detail, hopefully. But if you are just looking at it from the general surgery point of view, don't go into the details. Okay. Right. Now, this is something which can be asked to you. This is one of the favorite questions when the NB sets the paper for the NEET PG. So what is this? What is the sequence of correction? So when you are operating on this particular patient, what is the sequence of correction? So you first go ahead with the chordy correction. Okay. Then you go ahead with the repositioning of the urethral opening. So you first correct the chordy, then you reposition that particular urethral opening, and then you go ahead with the tubularization of the urethra. I hope you are able to understand. Do remember this. Okay. This is what is the sequence of correction: chordy correction, reposition of the urethra, and tubularization of the urethra. Now, that's all about the hypospadias. So quickly revise it in, let's say, 1 minute. What is hypospadias? Here, it is basically the most common urethral anomaly, 1 in 250 live births. Here, the ectopic, the urethra is opening at an ectopic location. So this is basically present on the ventral aspect. So it can be the anterior or the penile or the posterior anterior main. What we have is a granular and the coronal. Then we have a penile, we have a scrotal, we have a penoscrotal, and perineum. Now, these are different types. I told you that the most common is the distal, the most severe is the proximal. Okay, so we are done with that. Now, what is the problem? The patient is going to have the problem in the urination, the semen is not going to get implanted at the proper position, and there's going to be the flattening of the penis. The three characteristic features are dorsal hooded prepuce, ectopic urethral opening definitely, and the ventral cord. Okay, we will not go ahead with the circumcision. Why? Because that's something which can be used to create the urethra in the later stages. Now, when do you operate? This is something we should remember. Should operate before 18 months, because otherwise the child might consider it as a genital mutilating surgery. Don't bother about the names of the surgeries. Just remember the sequence. So the sequence is, first you go ahead with the chordy correction, then you have to go ahead with the repositioning of the urethra, and finally you go ahead with the tubularization of the urethra. So this is what is the sequence of correction in the patients with hypospadias.